Has the pilot changed your approach to teaching as a supervisor?
I don't think it's changed my approach. It's reinforced, to me, in my mind, the importance of goal setting and competency assessment in people who are going to be consultant paediatricians. And my view is that they should be at a level, when they're at junior consultant level, where they can function independently and do good assessments of children in these complex areas.
Thank you.
And that's the goal.
Yep. I'll put that out to the audience and ask the same question. Has the pilot changed your approach to teaching as a supervisor?
It has, because as we said, it's not a general feedback, it's a specific feedback, and the competency assessment is something which is really useful.
I guess I'm new to being a supervisor, and having only just recently, in the last couple of years, had an STP trainee. So I've had limited experience with the mini CEX and the previous format, and which was very vague, and I think somebody might have mentioned before that often related to how well you got on with your advanced trainee as opposed to the competency. And I think what the change here is, for me as a supervisor, it has helped me focus on those goals, which has been very helpful. But it's also made me more responsible, rather than just going through the motions of signing off. It's made me feel more responsible and made me ask the question as to what is this advanced trainee going to be like at the end. So I've actually had to, by looking at the goals, looking at whether they've achieved those goals or where at what point they are at, then I've had to assess how competent they are at the end, whereas I don't think I had that particular mindset before. So I've taken more responsibility for making those decisions at the end. Yeah.
Back to you, Nigel. What would you say are the biggest hurdles to supervising trainees at work?
I think the amount of time involved and the importance of one-on-one, so sitting in with them to see what they're doing and having them sit in and watch you. We get around it to some extent by, in the more complex clinics, when they start with us, we have an introductory program and we talk to them about the process of what they should be doing. For the autism interviews, we give them a template that they can sit and use and go through it. But they also get the opportunity to sit in with 3 different consultants so they can see, across the board how they do it and the differences. And then we observe them and we have a discussion back at the end of it. So the time is a big component. We also have we always make sure that when they're consulting, there's a consultant in the room next door. And on Thursday afternoon, when I have the 2 of them, I don't consult. I just sit there and do paperwork so that I'm available for both of them. So we sort of get around it that way. And the mentoring and feedback session is scheduled for Friday afternoon each week. So we have those in place. And I'm keeping more close records of what they're doing than I did in the past, and discussions that we're having, and particularly where I think there might be areas of competence about which I have concern. And I suppose the only other thing that I've come to conclude after 2 years with the STP trainees, who tend to be at a more junior level, although they're advanced trainees, is that I really need them for a year. 6 months is not long enough.
Okay. So a bit of induction phase, a very well organised setup, and time that it takes to invest in this, and perhaps a longer interface with that trainee.
I've got a very organised paediatric nurse who presents it for them and sits down with them, and they have a day with her.
Okay, excellent. Right, to the audience, what would you say are the biggest hurdles to supervising trainees at work?
I might just add to Nigel's comments that I think the organisation that's required, and the scheduling and the time factor. I was interested in your comment about how much time you actually gave, or how much clinical time you've given up in order to do that, because I certainly haven't done that. I've just added it on to the work I was already doing, and it's a very big effort to maintain all those things, I haven't actually given up any clinical time, and I'm starting to think that maybe that's what I need to do in order to continue to stay on top of all the other work that I have to do. So it's not that I haven't given the trainee the time they need, but it means all the other things I have to do in my work life are being neglected in order to provide the supervision that I know that the trainee needs. So I think it's interesting that you've been able to give up clinical time, but I guess that's one of the things that might be a challenge for many of us
Yeah, I'm sure
in
it
the
would
future.
be. I'm just too old to do it that fast now.
Yeah. Well, I'm not getting it done very quickly. I'm just saying that it's long days, I guess, is what the outcome has been, and I guess that's the challenge for all of us, is we have to decide what we're going to give up in order to do what we believe is required for the trainees.
Yeah, thank you, Murray. I'll just highlight that as a brave effort, actually saying, you know what, this is really important. And
Well, because I have a philosophical view, and that is at my age what I should be doing is teaching the next generation, not seeing patients. Seeing patients is important, but I can do that, and it's much quicker for me to see the patients rather than have trainees do it. But they're the people who are going to be doing it when I'm not here in a few years' time, and so they need to have those skills, and that's what we need to give them. So it's really almost one of my number one priorities in that sense, I think,
yeah,
or should be.
yeah, again, Brave's priority setting and a bit of a lesson for us all, I think, in there.
One of the things we did, I had a STP 1 position when I realized supervision was an important part of it, and it took the time. So the second position, when I requested for the STP, I asked for a 0.5 supervision STP BMO position. Instead of 0.5, they gave us 0.2, but at least that was better than me trying to spread myself thin.
Right.
So whenever we are asking for an STP registrar, I don't know if it will continue down the track, but looking at that supervision time,
Factoring that in.
factoring it in
Yeah.
is quite critical.
Yeah. So making it important enough to factor in and getting that message across. Back to you, Nigel. How do you fit in teaching and supervision of your trainee when you're working side by side with them?
Well, the way in which I reduced my clinical load was doubling the amount of time I have for each patient. And so that means I've got time to stop. And so if they come in or I need to go in and see a patient, I've got time and I can catch up. So it allows that opportunity. And I also limit the number of new patients I'm now seeing, and they go to the other staff. So most of the patients that I'm seeing, or many of them, are patients that I've known for a long time. And so it allows me the opportunity to go in, to sit and discuss. And there's always time at the end of the clinics too, where we sit and review their caseload. So if I haven't actually been in and seen the patients we've seen, they discuss them with me and they present them to me. And they're really good at that. I mean, they very much are like sponges and want to come in and learn and discuss. And one of the most interesting things that I find in teaching many of the trainees that we see, particularly the more junior ones, is giving them a framework or structure of capability. In other words, you can't be everything to everybody. You've got to identify what your skill set should be and the sorts of things that you need to be transferring and using other people within the team for. And so having them go and watch the allied health people, have them participate in discussions with the allied health team, and we do that in our developmental assessment clinic, where they actually talk to the allied health team who do it first before they see the patient. So they get some idea of how very experienced therapists are thinking, and that guides them to some extent.
Mm-hmm. Can I just ask on that, did you meet much resistance in your shift in emphasis towards more supervision teaching away from the churning kids through?
I'm really fortunate because I'm the clinical director and it's a relatively new service. I was able to set it up and got a lot of support from the organisation as to how I want to do it. Well, I'm always arguing with the finance director, and I've been sort of texting each other today about something else. It's just the way it is, you know.
Okay. Okay, I'll ask supervisors in the audience, how do you fit in teaching and supervising your trainees when you work together side by side? You're in the same location.
I think very much, as you said, Nigel, making sure that the trainees know that they can knock on the door, and then having a time at the end of the clinic where where it's assumed that we'll meet up for a chat if we didn't get to chat during the time of the clinic. I've been reflecting a bit on the pressures of working in a large organisation versus a smaller organisation where you might have a bit more autonomy, and I think it's really challenging at the Children's Hospital in Melbourne because it's all around efficiency and throughput. So something I mentioned earlier in the day in the feedback session at the back is that it's essential to have heads of departments who recognise training as an important priority for their department. And if they can support you in deflecting some of the financial pressures, that certainly does open up a space where you can be more efficient supervisors and have that trainee supervisor relationships kind of work a lot more smoothly.
Good comment. Thank you, Gihan. Vanessa, did you want to add something along those lines?
So the way mine was a new service, and the trainees came in with me on afternoon, particularly with my outpatient service. So this is a service which provides care for children with developmental, either suspected or confirmed developmental disability. So it's that first touch base: do they need an assessment, etc., what needs to be done, or the longer ongoing care of children with disabilities. And I run my 2 afternoon clinics where I have a trainee, is that we have sort of 2 sessions, so 2 till 3, they get a new patient, I see 2 reviews. There's no one booked, theoretically, between 3 and 3:30, and that's the time they feed back. They feed back to me in the other room that I'm in, and then we go back and we have a case discussion with the family. And then we do the same again, 3:30 till 5, with the same sort of hour and a half. They see a new patient, I see 2 reviews, then we have that wind-up time. When that works, it works fantastically. There are many issues and reasons why it doesn't work: patients running late, overbooked clinics, squeeze-ins, etc. But particularly at the beginning, that works really well with the trainees. What I've needed to do, or tried to do, is then step into the clinic to watch them do the outpatients, and that's the bit that I found the most difficult to do because of the load of review patients that are always there. So it's rare that I wouldn't have someone booked in.
Load for you, you mean, or?
Yeah,
right.
just in terms of there's always a wait list, and if there are empty spaces, they generally get filled. But trying to find a way and really thinking ahead during the 6 months, and I don't think we did that as well as we could have done, about saying, right, this Thursday afternoon there will be no one booked for me, and I will sit in and watch you. But that obviously means we go down from 6 patients to 2 patients, and we also have Medicare expectations and throughputs and waiting times that need to be thought about and have an impact. So I think that it's balancing those 2 things that have been a challenge, an ongoing challenge.
Can I just a supplementary on that? Do you think it's our battle at an individual supervisor level to be
No.
butting heads with the bean counters about this?
No, I don't think it. I don't think we can win it. I think it needs to be top down. So I think this is the discussion, that if this is the way forward, and I think we've all said that this probably should be the way forward, then this needs to be an LHD college discussion.
And there's another component to that. I mean, one of the issues that I'm grappling with at the moment is that there are certain expectations in another part of our organisation, and they want a certain level of service. And I'm saying, well, okay, I can tell you what you need, but this is what it's going to cost, and that's not my problem. Either you provide that level of service, or we don't have the service. You provide the funding, or we don't have the service. And that's the debate we're having at the moment. But, if there is a state government expectation, which there is here, and they're saying this is what you've got to provide, well, this is what it's going to cost. But that isn't my problem. I'll give you the staff and the service, but...
Wouldn't it be lovely if state governments and hospitals were willing to say to supervisors, yes, we'll give you that 0.1 or 0.2 or 0.3 or however much supervision time that comes out of your current clinical time, which would mean more jobs for young consultants coming through, but also just change the culture. And I think Canada does that quite a bit, where I think they prioritise research and education a lot. So some people have 0.5 EFT for just education and training, which is really quite lovely.
And that's what we've done. The 0.2 FTE which we got is just for education and training.
Yeah, that was very proactive. All right. Okay, Nigel, this next question is about how you fit in teaching and supervision in a situation where you're not side by side with your trainee. How do you actually make that work?
There's only 1 session a week where that happens, and so what we do is we carefully select the patients that go into that clinic, and so it's more of a neonatal follow-up clinic. So they're seeing babies who have more organic type needs, and so therefore we feel comfortable that they're off-site, but in fact I'm available to talk to, and they've got my mobile number and they ring me if there's anything that's an issue. So really we manage it that way. We make sure and we go through, and what I do is sit down with them before the clinic starts, and because they're in the same building the morning with me, and we go through their list and look at their patients and talk about the ones that are coming through before they see them, and then the next day or that afternoon we then review the ones that they've seen. So that's how we get around it.
Mm-hmm. Thank you. What about other people? But when you're not, other supervisors, when you're not working side by side or in the exact same location as your trainee, how do you make that work?
I feel like this might be true confessions, but so our community child health fellows spend half their time, so 2 days a week if they're full-time, out in a community centre where they may not have a paediatrician in that community health centre. It might be a health nurse office, for example. So they have distance supervision. They act really autonomously. So I think there's obviously a fair bit of entrustment happening at the start of their rotations. We do interview and select very, very carefully. So I think we know who we're getting up front. But having said that, it's for most of the trainees, it's their first time working outside of a hospital and using distance supervision. And what we do up front, and Viola might have a comment on this, she may or may not agree, but what we do up front is to say, look, you don't have to solve the problem on the day. It's okay to say, I'm going to take a history, I'm going to go back and speak to my supervisor, and I'll see you in 2 weeks, and we'll do the next bit of the assessment and formulation. So that's how we're doing it, for right or wrong.
Mm-hmm. Do you have any further, that the entrustment by default, that's a bit of a culture within our training program, isn't it? That it's in the spot first and find out about it later sometimes. So that's a bit of a major issue as far as I'm concerned.
It's a big issue. We have, again, the good thing about having a large-scale program is that we have lots of trainees and they all get together once a week for half a day, and that's, I think, quite a useful time for people to sort of benchmark against each other and share their anxieties. So one of the things we do is make it really explicit that for the first 3 months of your fellowship, you will be getting progressively more anxious, and that everyone does it. Yeah. But talk to your supervisor about it, acknowledge it, name it, and as you get to know the kids and assessments start coming back and you start reaching your formulation, that anxiety will settle. So that's a well-acknowledged emotional journey, I guess, as part of our 12-month fellowship.
Works the other way around too. I get very anxious for the first.
Yes.
We should write a paper on that. That's true. That is very true. Okay. And you emphasised, Paul, you emphasised selection as well in there of trainees for those more sort of distance supervision sites.
But I think as a trainee, especially trainees like that are coming towards the end, you need that entrustment clinics, those distance clinics, to actually do a clinic by yourself. How are you going to run that clinic by yourself? What are you going to do? And then you've always got, well, I know from my experience, you've always got your supervisor to potentially call up afterwards or to see the next day to chat about that case, and then if something needs to change, you can make a follow-up plan. But I think as you're getting towards the end, we're becoming consultants next. That's our next stage. You're trying to get everyone ready for that stage, and so in a ideal world with the college, what you should be doing is, having up these, as you're getting to your final year, you should be doing more autonomy clinics. You should have got to that stage where you are spending your year doing autonomy clinics with distance supervision.
Any other comments on that not next door supervision? That's it. Thank you very much, everyone. Thank you in particular, Nigel.